everyone, to this Obesity Institute seminar. And this week, we're, I guess, absolutely delighted, really, to be welcoming Caroline Steele. So Caroline is a consultant endocrinologist working with us. Oh, I guess we should do the next slide first, so just to remind everybody that in terms of housekeeping, the yeah, there you go. The event is being recorded, and I think it goes up on YouTube on the Obesity Institute YouTube channel, so everybody can rewatch, or if you have to leave at whatever point. And then on the next slide, I think it's welcome. So that's just to introduce myself. So I'm Dr. Jamie Matthew. I'm a reader at Leeds Beckett, and the reason I'm chairing this session is because I work quite closely at the minute with Caroline. So Caroline runs the Q service, so complications of excess weight clinics at Leeds Hospital. And we recently have been awarded quite a substantial grant working with a few different universities, mainly Sheffield Hallam University, to evaluate the whole national Q service. And that obviously includes the Leeds service, which is a site where we're doing some more detailed work, especially given its, I guess, geographical proximity. So Caroline has been part of that work and has been great to work with so far. So I think it should be really interesting to hear her thoughts on the Q service at Leeds. Just in terms of questions, I think it mentions it on the next slide. At the moment, everybody's microphone is muted and will remain muted. So if anybody has any questions, the best place to put them is this slido.com. If you enter the event hashtag LBU Obesity Institute, or scan the QR code on the screen, or click the link that Sunita has just put in the chat, then you'll be able to submit your questions there. That's the best place where we can kind of see them popping up live. And there'll be a Q&A bit at the end where I'm able to read the questions from Slido to Caroline, and we can have a bit of a chat around, depending on how much time's left. It depends on how many of the questions we get through. But if there's any kind of leftover questions at the end that we don't have time to run through, then we can send those to Caroline or myself, and we get answers to you. So I'll pass over to Caroline and let you take it away. Thank you. You're just on mute as well at the moment. Is it working?
Sorry,
It's okay.
Yes. I suddenly realised I couldn't unmute. Can you hear me now?
We can, yeah.
Great, sorry. Thank you, Jamie, for that very kind introduction. It's been really good developing the looking at the grant and things with you. So I'm looking forward to hopefully getting some answers and some evidence for the service. So what I'm going to talk today is about personalised care for children living with the complications of excess weight. So our service concentrates really on children with comorbidities of excess weight, but I'm going to talk more in general just about childhood obesity. Hopefully you'll learn a bit, if you don't know already, and I'm sure a lot of you will, about contributing factors and how we think about assessing and managing and treating childhood obesity. I'm going to quickly talk through our complications of excess weight service, which runs across the whole of West Yorkshire. And then finally, hopefully I'll have time just to think a little bit about the importance of non-stigmatising and supportive language to help reduce weight stigma. So we all know that there are lots of children and young people living with obesity. I think it's becoming more obvious, and it's been more obvious in the past few years, that actually these children are developing comorbidities in childhood and not in adulthood. And things like sleep apnea and mental health problems can be quite common and can dramatically affect the quality of life of these children. We know that early action can help to prevent long-term health problems, and that not only benefits the patients themselves, but society and the NHS as a whole, because obesity and its complications cost the NHS around £6 billion a year. There's estimated to be 157 million children and young people living with obesity worldwide. And whereas in the past people had tended to say it was something that children would grow out of, we know that 4 out of 5 children living with obesity will become an adult living with obesity. The classifications in adults, I'm presuming most people will know already. I think it's really good that there's been a move away from language like morbid obesity and excess obesity to using the different obesity classes. So in children, the definition of obesity, according to NICE, is a BMI above the 98th centile. And that's because BMI changes at different stages of childhood, and I've got some graphs to show you that. We know that comorbidities are much higher in anyone whose BMI is above the 99.6th centile, and that's equivalent to 3 standard deviation scores above the mean, and that's the language that we tend to think in and talk in when we're talking around our weight management services. And as a rough guide, a BMI SDS of above 3.5 is equivalent to an adult BMI of above 40. And as you can see from these graphs, if you have a BMI at 1 year of 18, then actually that puts you on the 3rd standard deviation. Whereas if you have a BMI of 18 at sort of 11 years of age, that puts you just 1 standard deviation above the mean. That's for girls. Up to 2 years, and the same for boys. So as you can see, the BMI of 20 at 5 again puts you at 3 standard deviation scores, and that's why it's important when thinking about childhood obesity to use standard deviation scores or BMI centiles rather than exact figures and numbers. So we know that more than 200 comorbidities are linked to obesity. Things like other chronic diseases, mental health issues, heart conditions, and some cancers and bone and joint problems. In children, these are the ones that we're commonly seeing: abnormal glucose tolerance or frank type 2 diabetes. Obstructive sleep apnea is very common in our population, as is metabolic dysfunction associated steatohepatosis, that used to be called NAFLD. In girls, teenage girls, quite often we'll see polycystic ovarian syndrome. Hypertension, we didn't see so much, but I think that was just because it wasn't being measured rather than it wasn't there. And dyslipidemia, we don't see commonly. I think probably more importantly in our young people is the psychological sequelae, things like bullying and depression. So there's a paper that shows that childhood depression inventory score correlates with BMI and waist circumference. There's also good evidence for low self-esteem, social stigma, and often this can lead to emotional eating. And quite sadly, there's a lot of discrimination still. And the bottom link links to a paper that talks about admission to university and higher degrees and things like that, and job opportunities. So what factors are linked with paediatric obesity? So the foresight diagram is very old, and that obviously links to obesity in general. Thinking about the person in the centre and all these things that influence the individual. The things we tend to think about in clinic are genetics. So I've got a few slides on genetics, which is not common, but again, is being more and more screened for, and I suspect the prevalence of genetic obesity will become more common as we're screening for it more often, and also as the various genes are found. We look for hormonal problems, which tend to be very uncommon. We very occasionally get young people with Cushing's disease. We know that thyroid, underactive thyroid can have an influence, but generally once treated doesn't tend to lead to a resolution of obesity. Things like sleep and stress are really important factors. Occasionally medications can cause your weight to go up, but I think probably the most important factors are the environment and also socioeconomic status. So when we last looked at our figures, about 50% of our patients lived in postcodes from IMD1, so the lowest decile of earnings, and 75% came from the lowest 3 deciles of earnings. So genetic causes are very rare, but there are genetics. So we're talking about single genetic causes, I should clarify. So multiple genes, gene variants aren't rare, and we know that most people's weight, probably 50 to 75% of your weight is genetic in origin, and that came from work from Ken, not from Ken Ong, sorry, the person's Giles Yeo and his lab. Staff Faruqi down in Cambridge has done some work looking at single gene disorders, and things like POMC and leptin receptor are being picked up along with melanocortin-4 receptor deficiency, as well as some of the syndromes that we see. So this is just an example of one of the genetic mutations. Your adipose tissue produces leptin, which crosses into your blood-brain barrier. That should stimulate your POMC neuron, which should then, through your melanocortin-4 receptor, lead to a decrease in hunger and an increase in energy expenditure. If there's a blockage in that pathway anywhere from POMC through to some of the other genes, through to the melanocortin-4 receptor itself, then these children and young people and adults, as they get into adulthood, just don't feel full at all and feel hungry all the time. And that is where, if there is a single gene cause, there is a specific medical treatment for that, although, as I say, it's very uncommon. We also think about regulation of appetite and feeding in terms of hormone in the central nervous system. So you've got your homeostatic factors, which will help you to balance what you're eating, how much you need to eat with your weight. However, there's huge influence from the non-homeostatic motivations to eat, such as food cues, the palatability of food and stress, and they can come hugely from the environment and your lifestyle. And then you've got within meal eating behaviours such as the speed of eating. Just going back to deprivation, you can see that from the National Child Measurement Programme last year, those living in that IMD1, that most deprived decile in reception, so age 4 to 5, were 12% were obese compared to 5.8% in the least deprived, so double. By the time you get to year 6, 30% in IMD1 were living with obesity versus 13% in the postcodes coming from the highest, so almost 2.5 times as high. So what contributes to obesity? This was from a cartoon artist where we'd attended in Leeds at the town hall, who'd done some great examples of things that we were talking about as we were going through. So things like food availability, the availability of things like food delivery services and takeaways, whether or not that food tends to be fast food or healthy food, money, and obviously that lack of space for physical activity are just some environmental factors that contribute. So obesity is a highly complex relapsing remitting disease which is driven by many factors. And the question is obesity a disease? And I think that's been quite widely discussed. I think there's many pros of thinking of it as a disease, which is probably helps it to make it a bit less stigmatizing and maybe recognises those genetic and medical causes. However, some people feel that there's cons with that and that they feel that it labels people as having a disease and it potentially gives blame to that. And we do know that there are some people living in healthy bodies at a higher weight. And so does that label of obesity as a disease then give them that unhealthy label? So to talk a little bit about our own service, and I've changed these slides. So I've presented this before and I'd started with a referral to Q service. And actually, I wanted to sort of get rid of that because actually, I think the patient journey starts with this. We know that a lot of our young people and children come into the service have had these experiences of bullying and stigma. They've been shamed and blamed by people from family members to parents to friends at school, and quite shockingly and sadly by school teachers, healthcare professionals, doctors, dentists. I could give you many different examples of shame and blame, and that can lead to anger and sadness in the young people. So hopefully this will work. It did when I tried it before. I just wanted to share the voice of the young people because I think this is really important. So if you can't hear the sound, then please let me know.
In children and young people. So ask me, for I am the one of millions of young people as myself who fit this category. I'm the one with so many health risks that are too frightening to think about, so I pretend I'm okay, but at night I cry myself to sleep. I'm the one what has to live in a society that values thinness. I'm the one who has to smile and endure the severe taunts from my peers, when deep down inside, I'm hurting so much, I want to die.
I am the one who has to wear all bigger clothes because specialists don't cater for my size.
I'm the one they label fat, lazy and greedy, but I'm so desperate to change, I just don't know what to do. So what do I need? I need someone to listen to me and help me feel better about myself as an overweight person.
I need to build up my self-esteem and my confidence so I can challenge the bullies, confront the discriminations which I go through every day.
I need to learn to be happy again and to leave my feelings of low mood and depression behind, which leads me to comfort eating and sometimes hating myself, just to make me remember I'm still alive. And I need a chance to explore how I became overweight in the first place. Maybe then I will be strong enough to take on the challenge of making permanent lifestyle changes that will help me to maintain my weight loss forever.
Maybe one day I'll like myself, and maybe expecting things to change is just a dream, but unless I try, I'll never know.
So please don't patronise me with eat less and exercise more. Walk in my shoes for a day and then tell me what you think. This is a letter to the professionals.
So hopefully I can move on from that slide. So I just wanted to have the voice of children and young people. And the first time I listened, that was really quite upsetting, and it still gets to me every time I listen to it. And so I think we wanted to provide the children and young people coming to our clinic with that environment that they wanted. So we've tried to make it fun. We've got a basketball net that we use. We've got a smoothie bike that children can put some healthy ingredients into that we provide, and get a bit of activity going. We do some education in our first session with them, and I'll talk about that in a minute. This is an example of some bioimpedance scales. We use the Tanita scales, and we get the young people to stand on that to measure their body fat percentage compared to body water, etc., etc. So we use that to talk to our young people about weight and body composition. We always try and make sure we have a compassionate approach of understanding what our children and young people have gone through. So what is Q? It's an NHS pilot programme that was rolled out across England approximately 2 years ago to address childhood and adolescent obesity by identifying and treating the complications of excess weight. We were encouraged to put a model together that was less medical and taken into account all of the factors which influence body weight. It was based on an MDT clinic in Bristol, and there was 3 parts of it. So the first part was to establish an optimal multidisciplinary model. So all of the clinics are set up slightly differently, all use slightly different mixes of healthcare professionals, and all have a slightly different model. That was important to help build the evidence behind not only what works best, but also the comorbidities that we were seeing out there in children and young people, and hopefully to improve system-wide data collection so that this can be evidence-based going forwards. And at Leeds, we'd had a weight management service where we were seeing about 450 young people living with obesity. However, it wasn't a funded service, and due to the complexity and the needs of these patients, we really just weren't seeing them often enough, and we found that we were just seeing more and more patients and being able to offer less and less. So we decided for our Q service we were going to make it quite an intensive process over 12 months and limited to 12 months, bearing in mind we know that obesity is a lifelong relapsing remitting condition, but the idea was to try and give that holistic and individualised, real intensive support for a 12-month period. We're able to see 100 young people a year, and that's children from the West Yorkshire ICB, so Leeds, Bradford, Calderdale, Kirklees and Wakefield. Sorry, I've spelt Wakefield wrong, which I've only just noticed. The referral criteria are quite strict due to the limited number of patients that we can see, and that's quite distressing sometimes because we know that there are a lot of young people who are struggling with weight and obesity that would like access to the service, but unfortunately we're just not able to see everybody. And we wanted to make it so that referrals could be both by medical and non-medical professionals. But because some of the criteria we use are dyslipidemia and hypertension, it needs that support from a GP or a healthcare professional if it's a non-medical referral. So on the West Yorkshire Healthier Together website and on the West Yorkshire ICB website, there is a link that you can find the documents on, referral documents. Alternatively, there's an email address for our weight management coordinator. So the form is a basic information form, obviously name, NHS number and things like that. It's very important to have blood pressure on there because, as I say, hypertension is one of our criteria. And we need a height and a weight so that we can calculate a BMI and a BMI SDS. We look for signs of underlying pathology. So the ones on the right-hand side of the screen, like short stature and sudden weight gain and puberty that's delayed or stalled, is to try and pick out patients who might have Cushing's syndrome, and they're seen in the endocrine clinics. And obviously, if there's a history of cranial irradiation or intracranial surgery, that might give more likelihood to there being an underlying pituitary or hormone problem. But also we know that hypothalamic obesity is common in patients. So again, it just makes us aware before we see those young people in clinic. Floppy at birth and NG fed specifically links to Prader-Willi syndrome, and that means that sometimes we can get the genetics done before. Knowing whether obesity started below the age of 5 years is useful because that would then lead to genetic screening. We ask about disordered eating, again, thinking about genetics or any evidence of hyperphagia. Other significant medical problems, obviously, we know have a big impact, and then we come to the comorbidities of what we will be looking for patients to qualify to be referred to the clinic, and also significant family history. We ask all patients to have bloods done unless there's a specific reason they can't, and that's because sometimes if there's evidence of fatty liver or dyslipidemia on the blood tests, we can then see those patients in clinic, whereas we wouldn't otherwise be able to. Again, for sleep studies, patients with obstructive sleep apnea would qualify for being reviewed by the service. Ideally, longer term, we'd like all patients to have been seen in a Tier 2 weight management service before being seen by ourselves. This is partly because our waiting lists are building up and partly because they can then come to our clinics with some background knowledge. Unfortunately, the service is quite disparate depending on where you live and your age, so that's not a criteria at the minute, but it's useful to know if patients have attended other weight management services. Also, if there's any other safeguarding concerns and any other services or agencies involved, just gives us a heads up before we see the children and young people in our clinic so that we can make contact with the relevant professionals involved. So our referral criteria for the Q service are less than 17.5 years at referral, and that's so that we can try and see them because we'll see up to 18 years of age. But we know that sometimes there can be that delay. So we've said 17.5 and that they live in the West Yorkshire area. They need to either have a BMI SDS and one comorbidity, as I've talked about before, or currently we are seeing patients with a BMI SDS of above 4.5, even without a comorbidity. But again, that may change over time as the service grows and as the demand increases. We start off by sending this cartoon that we got commissioned about our healthy weight clinic which we've found hopefully is a bit fun, a bit friendly, introduces the idea of the service as being a bit more relaxed, allows children and young people with neurodiversity to get an idea of like a social story about what will happen in clinic, and is helpful for our families where English isn't necessarily a first language. The ethos of the whole clinic is that it's no one's fault, and I've lost track of how many people, particularly mums, come to clinic and say it's my fault. So we're very strong from the start that it's no one's fault, that it's like any other disease, that there are ways to treat it and ways to help, but that it's nobody's fault and that there is no blame going to be attached, and that we'll provide support with living with obesity. And there'll be skills and expertise from many different healthcare professionals, and we're working as much as possible with community-wide organisations. As you heard from one of the young people in that video, it's more than move more and eat less, because otherwise there wouldn't be a multi-million-pound diet industry and we wouldn't have the growing epidemic of obesity that we've seen. Losing weight does obviously depend on energy balance, so amount consumed and the type and the amount of food eaten are important, and the amount used, so exercising and carrying out normal bodily functions. But that's a real dramatic simplification of obesity, and people living with obesity find that quite hurtful because it implies that they're lazy and they're not eating well. We use a multidisciplinary team approach with a couple of medics, a nurse specialist, our psychologist and psychology assistant, a specialist dietitian, a physiotherapist, a social worker who has been really good in helping with a lot of issues around school and funding and making sure families are getting the support that's needed, and they can look after the wider family, which is really helpful, as well as our youth worker who can go out a bit more into the community and provide support, and our MDT coordinator who tries to keep things running smoothly. They come to a first welcome session, which is with other families attending clinic, and they don't actually see a doctor at that appointment other than just to say hello. It's an informal meet and greet session. There's some information given around the help that they're going to be provided with. We ask them to fill in some questionnaires so that we can get an idea of where things are up to with various things and what to expect when they come into the Healthy Weight Clinic. The feedback that we've had has been really positive so far, and people have found it quite non-judgmental, and finding out the approach that was going to be used they've found helpful, as well as being able to access and speak to different professionals. A lot of our children and young people live with ADHD and autism, and as I mentioned before, a high incidence come from very deprived areas or have low incomes. And we also have a lot of families where children and young people are living with mental health issues such as low mood and anxiety, and we try and keep all those things in mind. We tailor our service for different developmental stages and needs. So we first of all age stratify the clinic. We have a 12 and under and a 12 to 18 separate clinic, where we hope to be able to provide more family support and peer support with tailored advice and information, and using different means of communication and different play and activities. As I've shown you, we have lots of cartoons to illustrate the service, and that, as I say, has been helpful for our children and young people living with these additional needs, such as learning disabilities and autism. We also try and have a quiet space in our clinics so that if young people are finding those group sessions a bit too much, they can have a bit of a breakout from those. And we can also try and adjust the advice given depending on sensory needs and challenging behaviours. And our psychologists have developed some more social stories. So these are just an example where children and young people can see what being healthy might mean to them, who might be there to support them, and to think about the choices that they can make to help their body to be healthy. Usually in the hospital, we don't have face-to-face interpreters, but we felt very strongly that for this first meeting and this first education session, it was really important to have a face-to-face interpreter where that was needed. There's the opportunity to meet up with our social worker and complete some of the questionnaires. So the SDHQ I'll take you through in a minute, to think about finances and cultural aspects and how that may affect our families. And we offer telephone and virtual appointments where possible to try and reduce the need to travel to Leeds, although we've found in general a lot of our families prefer coming face to face. So the SDHQ is the Social Determinants of Health questionnaire. So it goes through questions like access to affordable and reliable transport, being able to pay for housing, electricity and heating bills. And we know that these things can have a significant influence then on what families have then to provide food and maybe the space that they have sort of mentally to be able to think about some of these things. So by asking them to fill in this questionnaire at the start, we can be aware of any issues and where we might be able to provide support through our social worker and where we may need to take these things into account. We use goal-based outcomes, so to ask our children and young people to set their goals. Often it'll be, I want to lose weight. We try and make it more specific, so it might be, I'm not eating lunch at school because I feel very self-conscious, so I'd like to be eating lunch at school, or I'd really like to try out for the football team and have the confidence to do that. So we're hoping that by giving them a specific goal that they've set themselves, that will help to guide them in making some of these changes that they'd like to make. We get feedback from families and young people at each clinic, some of which I shared before. We look at the PEDS Qual, which is the Paediatric Quality of Life for 8 to 12-year-olds and 13 to 18-year-olds. So the older young people will fill in their own measures and the younger ones, just parents will fill it in. And that's to measure their quality of life, as well as the psychology wheel that our team use, where we can try and look at their well-being and health experiences. We've got a youth group which has unfortunately not been running so well as our youth worker hasn't been available, but we're trying to encourage that youth group so that we can hear the voice of the child and the young person and encourage them to have some peer interaction. And we've also done some patient and public voice work in conjunction with the Association for Young People's Health and the NHS England project for the Q Clinic, and again through the NIHR grant that Jamie was mentioning before. There's some PPI work in that, which I think is really important. Our youth workers got access to sort of free and minimal cost activities in local areas. Our psychologists sometimes do home visits, and we look at thinking about systemic interventions. So we liaise with school and third sector organisations where possible to try and facilitate that holistic support that we were talking about. So after we've assessed all those factors, we come up with a plan which tries to come from the patient, but with input from all our different specialists. And then we give our patients a ring to see how things are going. We've changed from calling them once a week to check that they're okay to a more structured intervention and approach. But we haven't updated our cartoon. We haven't had the funding to be able to do that. We try and interact with the tier 2 services where possible. Obviously, school is important, as is social care. So as I showed before, we've got some lifestyle interventions which we try and show in clinic. That's Paul, who was our specialist nurse with one of our young people on the smoothie bike and the basketball net, just to show that activity doesn't have to be going out and running a marathon or going swimming or anything active. It's just thinking about what kind of things can you do, what kind of things can you get yourself off your backside and doing and just increasing that physical activity. And we also give out step counters. Some of our patients will have a psychological intervention, so one-to-one formulation around their relationships with food, if that's a problem. And again, we're hoping to begin a therapeutic group. And we use medications very rarely, but they are available. Orlistat has been the main one that we've used in the past, which is a fat blocker, which is horrible, which most people don't want to use and won't continue to take. For patients with specific gene changes, setmelanotide and leptin can be used. And then there's the GLP-1 analogues, which we know work very well in children and young people, but unfortunately there are ongoing funding issues around that. Obviously, if there's any underlying health conditions such as Cushing's or hypothyroidism, we'll treat that. We haven't yet referred patients for bariatric surgery, but that's an option. And then those systemic interventions I've mentioned before. Just moving on to language around obesity, because I think that's very important. And often I think people struggle to know what language to use because they're trying not to be offensive, as well as when people can use language to intentionally be hurtful. And we know that obesity and weight-based stigma leads to stress. It can lead to increased cortisol and increased eating, which leads to weight gain, which can lead to more obesity and weight-based stigma. And so this can be a vicious circle for young people. Teasing and bullying, as I said before, unfortunately is widespread and it's very harmful to young people. And children and teens' mood and self-worth can be significantly impacted. But there's not always a policy or intervention within schools and within workplaces for teasing and bullying. We know that in schools there are so many different priorities that actually thinking about this may not be a priority, and how it could be addressed can also be quite difficult. The Action Teens was an international study that looked at how teenagers were feeling within obesity management. The UK was one of the centres, one of the countries involved in this. And it's really interesting because when you look at the adolescents' views, about 75% of them recognised that their weight was above normal. And a lot of them did worry about the impact on their health. And about 60% had tried to lose weight. And the commonest motivator for weight loss was wanting to be fitter and in better shape. And they felt that the barriers really were lack of hunger control. They found that discussing their weight with a healthcare professional led to negative feelings in about 47% of adolescents. But actually, despite this, 76% of them felt that they were pleased that it had been discussed and felt that it was useful. But nearly 2/3 of them thought that it was their responsibility alone to lose weight. So interestingly, only about 66% of their caregivers thought that adolescents' weight was on the higher side compared to normal. And again, they tended to worry about their impact on their health. 45%, so nearly half of caregivers believed that adolescents living with obesity would slim down with age, and we know that that's not the case. They most commonly thought that weight loss motivators, again, were wanting to be fit and in better shape, but only 32%, so it was much less conclusive within that group. And again, they felt that for their young people, it was a lack of hunger control. So this is important because this is quite different to what healthcare providers were saying. So again, slightly worryingly, 24% of healthcare professionals thought that adolescents would slim down with age. And really, they thought the most common motivator to losing weight was improving confidence and improving their social life. So that's quite different to what young people were actually reporting. And I think we're potentially not giving young people their due in them realising the impact on their longer term quality of life. And healthcare professionals just really felt that it was unhealthy eating habits that were leading to problems with weight loss, whereas young people and their parents were really reporting problems with hunger. So when we're going to speak to these young people about childhood obesity, how do we take all those things in mind and where do we make a start? So the 5 steps on childhood obesity is being described and published. So the first one is to initiate that conversation by asking for permission and starting the conversation. And we try and do this in our clinics. It's much easier to do it in my sort of general endocrine clinics because patients haven't come for their weight to be discussed, but I do always try and start even within that weight management setting to say, obviously that's why you've come to clinic, but I'd still like to make sure it's okay with you that we talk about this because we know that it can be quite sensitive. For our young people coming to the Q clinic, they've already been weighed and measured and their BMI percentile or SDS has been calculated. But for those where it hasn't happened, that's an important step to see where children fall on that percentile. We'll then discuss with them the things that have been going on, take a history as you would normally in an examination and think about the treatment and the follow-up. So I've already talked about confirming permission with the child and carer that they're happy to discuss it. I think if you're in a setting where children don't give permission and don't want to discuss it further, it's important to build that relationship with that family and keep that relationship there and say to them, that's okay, I'll be here to discuss it at a later date if you change your mind. So some of the suggestions from the 5 steps are things like, I see more children these days who have overweight, but there are lots of options to help us manage this. Do you want to talk through and set these up as a plan? Or thanks for allowing us to talk about this. Could we talk about some different options? And try to avoid talking about weight and obesity, more leaning towards thinking about growth and health and how young people can tailor that. And try and develop an understanding of the aspects of health that are most important to the child and family. So as I said before, it may be joining a football club, it may be having the confidence to eat lunch in school, and using open-ended questions and summarising what you've heard to ensure that you're aligned with what the family is saying to you. It's quite easy to go off onto a different topic, and I hope I'm not being patronising in saying this. I know a lot of healthcare professionals will learn this as they're going through their training, but I guess it's always just worth reflecting on the basics to ensure that you're doing those things. It may be the first time that weight's been raised with them, so if you can be reassuring and supportive and try and steer away from that sort of critical response that young people have had. And certainly for our younger people where they're growing, we think about maintaining their weight or slowing their weight down rather than losing weight, because they can grow into it as they get taller, and that taking action early on has that longer term chance of improving children's health and their future. So there's lots of images and resources out there. The 5 Steps to Childhood Obesity is one of the links, and there's some nice images that are non-stigmatising from the World Obesity Federation. So my take-home messages are: obesity is a disease. I think it's highly complex, progressive and relapsing and remitting in nature, driven by many different factors. And it's quite difficult to take all of these factors into account. But by doing that with support with the skills and expertise of different healthcare professionals and community-wide organisations, hopefully we can help young people to understand a bit more around their obesity and their weight and what's driving that, and to emphasise that it's not their fault, but things can be done to change it and make it better. And that's the end of my presentation. Thank you.
Thank you, Caroline. That was perfect. Brilliant. Perfectly to time as well. Well done. Made my job a lot easier. So there's a few questions in the Slido, so I thought I'd just read them in order, if that's all right with you. So the first one is, they wondered whether you personally found it enjoyable and or rewarding to deliver the Q clinics.
Definitely. I've been working in sort of the area of obesity for a long time now. I did my PhD about 10 years ago with adults living with obesity due to hypothalamic damage, which is a very specific area. And it's been increasingly frustrating, really, seeing this lack of support that these young people were getting. And as I say, we'd had sort of 450 patients in our clinics where we knew really we couldn't offer anything. So the Q Clinic's been great in that it's given us that opportunity to have a multidisciplinary team approach. And I always say my job's probably the least important out of everybody. I think it's getting that support from those specific areas. So it's great to be able to have the funding to do that. It's fantastic over the last few years to see some of these obesity medications coming through and to see how people's attitudes have changed over time and are still changing, and there's still a long way to go. But that's been really exciting. And mostly working with the young people. There's some fantastic young people who come to our service. They're all very different. They've all got different backgrounds. They've all got different struggles and stresses and strains, but you know, the young people who we as a team work with, and the team gets on really well, which is fantastic. It's a great team to work in. So yeah, I've really enjoyed it. There's obviously the frustration still around the stigma, around use of medications, around not being able to offer the services to everybody. But I've yeah, generally I really enjoy working with the young people.
That's really good to hear. There's another one from Jess Large, who's a paediatric dentistry registrar working in the Sheffield Q Clinic. She's asked if you've noticed a high prevalence of dental decay or dental problems amongst the children that are attending. Do you ask about oral health? They've noticed a history of current dental problems and or lack of a family dentist as a problem in the Sheffield Clinic. There's an association between the obesity and the dental decay, and they have an established pathway to support children to access dental care. And then she's left her email to discuss further. I don't know if you have a response to that at the moment.
Yeah, no, it'd be great to discuss further. We've been working with our dental hospital, and we'd had a discussion around, would we try and have a dentist come in? Would we have a referral pathway through to the dental team? Would we sort of make specific reference to it in our examination, and talk about sort of dental hygiene and checking for a dentist at our first Q appointments? I think the difficulty is there's so many aspects to take into account that's something that we decided not to routinely include, but obviously to try and make note of. But I think it's something that, again, possibly we need to revisit and think about. It's that balance, I guess, between providing as much help and support as you can versus feeling overwhelmed. And it may be something that perhaps, so we do 3, 6, 9 and 12-month reviews, and perhaps that's something that we could revisit at our 3-month reviews and put that in as a standard question. So I think, yeah, absolutely. And we notice, we know that deprivation, obesity and dental decay are all very strongly linked.
Definitely. It'll be interesting because we're doing the national evaluation of all of the Q clinics across the country, and they've all adopted different models of care and they're assessing different things. And I guess the idea of that is to see who does what, how, and which works best. So it'll be interesting to see as well, Jess, how other Q clinics are assessing that, because I think that's included as part of our questions.
Yeah.
So the next question is, do the Q clinics work with neurodiverse children and young people with ARFID, which is avoiding restricted food
intake disorder?
Yeah, that's the one.
That's the one.
Slash restricted diets that don't have excess weight currently, but could have an impact in the future.
Yeah. So at the minute, we only accept children and young people with a higher BMI. We do have, so I'd said 3.5 SDS as a cutoff with a comorbidity. We do have some young people whose BMI SDS doesn't quite meet 3.5, where we think that there may be additional risk factors. So I know obviously in adults living with obesity, ethnicity is a sort of a risk factor. So there's been discussions around moving sort of those cutoffs down. So we do have a young person who we think has ARFID within the service who is obese. I think it'd be important for us to think about how we work with different healthcare professionals to try and think about that. I think preventing the obesity in the first place obviously would be extremely important and a massive benefit. But at the minute, obviously, our resources are quite limited, so we are just working with children and young people living with obesity. But I think sharing of resources will be great. And our psychologists do speak with our eating disorders team, where there's concerns about our young people who are living with obesity who also may have eating disorders. And obviously that's some of the work that we're doing with yourself, Jamie, around looking at sort of eating disorders within obesity. So I think there's a huge need for development within that area.
Thanks, that's great. And then the next one is, I guess, an interesting one. What would you, I guess, personally say is success, kind of in quote marks, for a young person attending a Q clinic?
Yeah. I think we've got all our typical medical outcomes of, you know, weight's improved, BMI SDS is improved, and you know, hypertension's resolving and sleep apnea is improving. I think if we can achieve those things, that's fantastic. I think within a year, it's very difficult to see those physiological changes. And actually for our young people, our psychological outcomes, I think, are equally important, if not more important. And that is something that we do look at in our clinics. So some of our young people we know are generally feeling happier and better in mood. They're attending school more, which obviously helps massively with their confidence and is a positive cycle rather than a negative cycle, and increases our life chances. So I think for me, it's anything where we can see positive changes, whether it's physical or mental health or psychosocial. I think it's everything really, just seeing children happier as a whole, and it doesn't always happen. We have, unfortunately, lots of young people where the changes aren't significant, but hopefully we've potentially sowed the seeds and laid a bit of groundwork for improving things in future for them. I don't know whether that answers the question. It probably sort of skirts the issue a little bit, with which I think is the most important.
Yeah, I completely agree, and that's you know, whether BMI SDS might have changed, but then, you know, if school attendance is going up, then that's a positive. But then what if school attendance has stayed the same, but engagement at school has gone up whilst their attendance is still the same? So there's so many different aspects to look at, which I guess is why the evaluation is turning out to be quite complex.
Yeah.
The next question was, at what point would you refer for bariatric surgery? So
I think obviously we'd look at our children and young people sort of, we have them for a year. We do actually extend. So we've got some young people that we've found that sort of all of a sudden, sometimes 12 months, they're getting that confidence within the team to sort of divulge stuff or share stuff that they've maybe not shared before. And so particularly from psychological aspects, that can be quite difficult then to discharge the young people at that time. So we kept them on for sort of 15 to 18 months. Our patients, we do have about 10 to 12 patients on liraglutide. We keep them longer. So we haven't as yet referred anybody for bariatric surgery. We've got 2 patients that potentially, I think, may need that. So I think one of the advantages is, before you sort of undertake bariatric surgery, you really need to try all these sort of lifestyle interventions anyway, and have that sort of psychological assessment. So as I say, we've got 2 young people, one possibly not has other underlying medical needs which may be driving the obesity, and one whose weight is above 200 kilos. So I suspect that young person is going to really struggle to actually lose a significant amount enough amount of weight that it will make any physiological changes. So I suspect that towards their end of their year of care, we may address that, but we actually haven't yet referred anybody. I suppose really it's when those lifestyle and dietary and changes that we know don't always work haven't helped. And I think then there's another interesting debate around medication use and bariatric surgery. And I think they're starting to look at national commissioning for bariatric surgery. So sort of, I know within adults there's more defined pathways. I think it'd be interesting to see what those pathways are then, and who should be referred. And it's really difficult. Obviously, it'd have to be post-pubertal to want to make those referrals.
Yeah, I wonder whether the strength of some of the new GLP-1 analogues, like the newer kind of classes coming out, will kind of mitigate some of the need for younger bariatric surgery.
Yeah, absolutely.
So we've just got a few minutes left, and there's 2 questions left, so I think we might have time to get through them all. So the penultimate one is, do your families referred onto the service maintain up until the 12 months, or do you notice a drop off before that?
In terms of attendance?
Yeah, I guess in terms of attrition, kind of whether people are still attending at the end.
Generally, we tend to find that if they've come for the first few months, they tend to sort of stick with it till the end. We do have, you know, a percentage of young people who are just frequently not able to come to the clinic. So generally it depends, as I say, on their early attendance is usually a good guide, but we do certainly have a significant percentage of patients that just aren't able to come to the clinic for whatever reason. We haven't got our latest figures. We had looked at that, and initially our sort of was not brought rates were quite good, but we've noticed we've moved slightly out of the city centre, and we've noticed that those rates have increased. We're hoping to move back into the city centre soon, so it would be interesting to see what difference that makes. Generally, once they're in the service and they're getting the support provided, I think families generally have stuck with us, which has been quite nice.
Yeah. And that's another question that we're looking at in the national evaluation, the kind of what the uptake is like, what the coverage is like, what the attrition is like, and so on, and in what populations, why that might be different. So
yeah,
something that we'll be looking into. And then the final question that's on the slido is, within the school nursing service, we might want to make sure we are sharing the right public health information in terms of weight management without simplifying it to eat well, move more. Have you got any advice for sharing this information without simplifying it too much?
Yeah, I mean, I would say feel free to drop me an email, or drop our weight management team an email. We can share some resources that our dietitians developed. We are looking at how we can work with sort of different services across West Yorkshire to try and sort of share that information, and I'm hoping that we're hopefully getting a dietetic assistant soon, and one of the things I'm hoping our dietitian will then have more time to do is to go out and think about sort of teaching and training and sharing of resources with families. So I think it is important to bear in mind, you know, the healthy, you know, the healthy eating plate, food portion sizes, and things like that, as well as activity, but also bearing in mind the barriers that families might have. So I guess just thinking about that in general. But as I say, if you want some specific resources, I'd be more than happy if you drop me an email, or drop my colleagues an email, and we're certainly trying to do some sort of teaching and sort of learning sessions, because we always find that we learn lots from people working in those services about how to get the relevant information, so culturally sensitive, using sort of easily to understand language, into community sort of at place, rather than sort of seeming like it's coming from this sort of, you know, tertiary level centre. I think it's much better if it comes from healthcare professionals working already with the families.
That's brilliant, and I think we're perfectly to time, and I guess I just want to say a huge thank you for delivering that. I found it really, you know, brilliant, the work that you're doing, really well delivered. Thank you. And there's a comment in the chat that said this was a really useful training, talking about the kind of 5 the steps at the end that you mentioned. They said they're really enjoying it. So thank you very much. Caroline, could I just catch you at the end? I've just got a work-related question about the project. Sorry, before I catch you while you're here.
No, that would be great. I think that's the last slide, is it?
Yes, that's the last slide, yeah.
I'll leave that up for people to look at.
That's perfect. Thanks a lot, everybody.
Thank you, everybody, for coming.